evening, everyone. On behalf of the Integrated Health and Wellbeing Council, I welcome all of you to this session powered by RG Hospitals. I'm your host, Dr. Behjat, and today we'll be discussing about understanding urological malignancies. And to talk about this very critical and pertinent issue, I have with me Dr. Ajay Aggarwal, who's a consultant urology at RG Stone Urology and Laparoscopy Hospital. Welcome to the discussion, sir.
Thank you, ma'am. Good evening. Thank you.
So, Dr. Ajay, when we talk about malignancy, especially in perspective of urology, what are the different types or what kinds of malignancies are there specifically when we discuss about urology?
Ma'am, if we talk about urological malignancies, there are various malignancies which encompassed in urology. The first one, which is most common in urology, is prostate cancer. Other malignancies which is common is renal cancer. Third one, urinary bladder carcinoma, testicular cancer, penile cancer, and other malignancies which are less common, like urethral carcinoma, like upper tract carcinoma, seminal vesicle carcinoma, like these. These all malignancies forms a group which come under urological malignancies.
Thanks for that information, Dr. Ajay. So we'll be talking about one malignancy at a time.
Sure.
So you said the most common one is renal malignancies. So what are the early symptoms when we talk about that kind of malignancy?
Ma'am, the most common is prostate, but first we talk about renal malignancy. Renal malignancy means malignancy in the kidney. The most common presentation of renal malignancy is asymptomatic. 50% of the patient present with asymptomatic renal mass. There is a classic triad which is explained in the books for the renal malignancies, like flank pain, abdominal mass, and hematuria, means blood in the urine. This is the classic triad, but in all patients, this classical triad is not found. In some patients, it is found. So the main diagnosis is relied on clinical examination and the investigations. The presentation is like this, and then we take the history and clinical examination and further investigations. So after this, we diagnose renal malignancies.
How is the diagnosis done if we talk about the diagnosis part?
Ma'am, firstly, as I said, we take a history. Patient presented with history of hematuria off and on, flank pain off and on. And on palpation, we found an abdominal mass, a swelling in the abdomen. Then we go for a first investigation, we go for an ultrasound. In most cases, ultrasound found something like any mass, any heteroechoic, heterogeneous mass, which is found on ultrasound. To confirm that mass, whether it is a malignant or benign, we advise a CT urography, triple phase CT urography. In that, we confirm whether this mass is a renal malignancies, because some renal masses are benign also, which can be confused with malignancies. So in that case, CT scan confirms our diagnosis that it is a renal malignancies. So the mainstay of diagnosis depends on the CT scan.
So CT scan is the most important tool when
yes,
it comes to diagnosis. What about the management? When it is diagnosed that the person has some sort of renal malignancy, how is the treatment, the management journey looks like?
Ma'am, once it is confirmed that it is a renal malignancy on CT scan, there is a classification system in each of the malignancies, whether it is prostate, whether it is renal, whether it is testicular, there is a classification system, which is called as TNM classification system, tumor node metastasis classification system. According to that system, we first classify the patient that in which category the patient is in type of renal malignancies, like he is in T1 classification, T2 classification, then according to that, we go for treatment. But the mainstay of the treatment in renal malignancies is radical nephrectomy. In some cases, in some case, a malignancy is present in the upper pole, like in the upper part of the kidney, not involving whole of the kidney. Then there is no need for radical nephrectomy. We can do partial nephrectomy. We can remove that part which is malignant and we can save rest of the part. This is called nephron sparing surgery. We are preventing the whole kidney to be removed. We are removing some part of the kidney which is affected by malignancy. So these are the options, either partial nephrectomy, or radical nephrectomy. This is the mainstay of the treatment. Other options are also available depending on the stage, depending on the condition of the patient, status of the patient. Like we evaluate the performance status of the patient, whether patient is having comorbidity, patient is having any previous history of any disease, patient right now, how is the patient, whether he can survive the surgery or not. So after considering all these options, we go for different management like surgery, either in some cases radiotherapy. In some cases, when the tumor is inoperable, we cannot operate the tumor. In that cases, we have to do embolization due to reduce the mass of the malignancy and then go for surgery. And in some metastatic cases in which the malignancy is spread in all over the body, we can give chemotherapy or immunotherapy and do a salvation nephrectomy so that the patient can be relieved of its symptoms. These are all the options, but all options have to be considered after the patient performance status and patient conditions.
So that indeed was a very nice overview that you had given, Dr. Ajay. Talking about prostate cancer, right in a system, symptoms, how it is managed, what are the treatments available?
Ma'am, prostate cancer is the most, if we talk about epidemiology, prostate cancer is the second most common cancer worldwide in males. Since the prostate is the gland present only in males, so it is a cancer of males only. In prostate cancer, we normally encounter lots of patients of prostate cancer. The main presentation of prostate cancer is similar to a presentation of prostate enlargement. Most of the patients of prostate cancer presented with symptoms of prostate enlargement, like they might be having frequency, they might be having urgency, increase urination in night, straining while urination, all the symptoms of enlargement of prostate. We cannot differentiate between whether patient is having benign enlargement of prostate or whether this patient is having cancer prostate. So after assessing the symptoms, we evaluate the patient whether he is having malignancy or not. A common screening test which is done is serum PSA. It is a very good test to diagnose prostate cancer. In some cases, it is also not very specific. In some cases, like urine infection, recent urinary instrumentation, whether in previous disease, if we put some catheter in the patient, then also it can rise. Like in prostatitis, these are the conditions which can cause falsely elevated serum PSA. So serum PSA is not the wholesome, but most of the time serum PSA give us an indication that patient might be having prostate cancer. Once we have suspicion that patient might be having prostate cancer, we first do the DRE of the patient, digital rectal examination. We put a finger in the rectum of the patient and palpate the prostate. Most of the time patient is having, if the patient is having prostate cancer, most of the time patient will be having hard prostate, nodule in the prostate, which confirms the diagnosis. But the actual confirmation stays on the biopsy of the patient. If the patient is having, if we are suspecting that patient is having prostate cancer, first and foremost part, most important part is biopsy of the patient. TRUST biopsy, we call this TRUST biopsy, transrectal ultrasound guided biopsy. We ultrasound guided put a probe into the rectum of the patient and take 12 pores in each of the part of the prostate. From the right lobe, 6 part, left lobe, 6 part. Total 12 pores are taken. Then after biopsy report, it is confirmed whether the patient is having CA prostate, cancer prostate or not. Remaining other investigations, like nowadays, because TRUST biopsy is an invasive procedure, patient feel pain in that procedure. So nowadays, we usually do multi-parametric MRI pelvis with prostate. It is a non-invasive procedure. We do a simple MRI. In that also, we get some idea whether patient is having CA prostate or not. In that MRI, we are having classification regarding the lesion of if the patient is having CA prostate, patient will be having lesion in the prostate, which will be detected on the MRI. These lesions will be classified like 1, 2, 2F, 3, and 4. We called it as a pirate scoring. If the patient is having pyretes 3 or 4, that means patient is having higher chances of malignancy. Patient is having 1 and 2, that means patient is having more chances of benign. So after that, we then go for trus biopsy, because without having histological diagnosis on biopsy, without having tissue diagnosis, we cannot start the treatment of the prostate cancer. So we have to have confirmed before treating the prostate cancer. So this is the overall methodology how we can diagnose a prostate cancer.
Coming to another kind of malignancy that you have pointed out at the beginning of the discussion, when we talk about renal malignancy, what are the early symptoms? How is it diagnosed when we talk about renal malignancy?
Ma'am, as I earlier said, renal malignancies, kidney malignancies, both are same thing. We diagnose asymptomatically, patient come with us to us, and then we diagnose with CT scan, which is the mainstay of the treatment, mainstay of the diagnosis. Then we do the treatment according to the condition of the patient. I have forgot to tell you about the management of the CA prostate. In management part of the CA prostate, there are usually various kinds of management available. Similarly, depending on the condition of the patient. The first thing we consider while doing treatment of the patient is the life expectancy of the patient. In books or in protocols, it is written that if the life expectancy of the patient is greater than 10 years, we can go for surgery. And nowadays, the surgery of prostate cancer removal is called radical prostatectomy. Initial days, it was done in open method. Then came laparoscopic method. But nowadays, robotic method is very prevalent. In that method, there is excellent view for removing prostate cancer, and there is minimal bleeding. So nowadays, robotic radical prostatectomy, RARP, is becoming very common. So the best treatment for prostate cancer is radical prostatectomy if the patient is eligible for that. I mean to say eligible means if the patient's cancer is not metastatic, not locally advanced, the patient is having localized disease, and the patient is not so old. Like if the patient is 90 years old, we avoid doing that surgery because the life expectancy is not more than 10 years. So other methods should be adopted. Other methods besides surgeries are radiotherapy. In some cases, radiotherapy is given. In cases where nothing can be done, like surgery or radiotherapy, we give hormonal therapy. We call it as androgen deprivation therapy, ADT. In that, we inject a injection every 3 monthly or 6 monthly to a patient to cut the testosterone supply to the prostate. We basically medically castrate the patient, because the main cause of the CA prostate is testosterone. So we castrate the patient medically and continue on that. After some time, patient might become castrate resistant. That means that injection stopped working on that patient. Then we add second line of treatment like immunotherapies. Like there are various medications now in market available like abiraterone, enzalutamide, and ultimately chemotherapy. So this is the stepwise approach to treat a prostate cancer. In prostate cancer, in some patients, we also do watchful waiting or active surveillance. Like if the patient comes with very small lesion in the prostate, patient is in his 50s or 40s, and patient is having no symptoms, and patient PSA is not also very high, and PSMA PET, we do a PSMA PET scan to know the metastasis condition of the patient. If that is normal, then we give the option to the patient whether you can go for active surveillance. That means we do not do any active thing. We do every 6 monthly follow. If the cancer of the prostate increases, then we do active management, because the prostate cancer is a very, very slow growing cancer. So in some patients, the lesion which is present in his 50s, it is the same lesion which is present in his 80s. So to avoid the difficulties, to avoid the harmful effects of the surgeries or any therapy, we can give option of the active surveillance to the patient. This is a unique part in prostate cancer that which we can offer to the patient. This is the broad management part of the CA prostate.
Thank you, Dr. Ajay. You have very nicely pointed out about the treatment modalities when it comes to prostate cancer. Talking about urinary bladder malignancies, what are the symptoms? How would you diagnose it? Give us an overview on that.
The most common presentation of urinary bladder carcinoma is painless hematuria. Patient will complain of having hematuria, blood in the urine without any pain, and also associated with its clots. So this is the most common presentation. In history, you will also get to know about his smoking pattern. Patient will be in his 50s or 60s, but nowadays we have encountered many patients in 30s also, they are having CA bladder. So most common is painless hematuria, then sometimes dysuria, and then we start evaluation for the cause of hematuria. The first and foremost investigation is ultrasound. In ultrasound, we get to know about any lesion in the urinary bladder if it is there. Sometimes there is no lesion, but the wall of the bladder is thickened, which is, I can say that initial stage of the tumor development. So in ultrasound, we miss that, and sometimes then we go for CT scan. Similarly, CT urography. In that, we can diagnose whether it is carcinoma or not. Once the carcinoma is diagnosed, we go for treatment of the bladder carcinoma. Now, regarding the treatment part, ma'am, if the patient is having overt lesion in the bladder, first and foremost treatment part is go for transurethral resection of the tumor. We go inside the bladder, we remove that part of the tumor, full part of the tumor, and we send that tumor for the biopsy. After biopsy, as I earlier said, every malignancy has its classification. After biopsy, we classify the patient into group, whether the patient is having non-muscle invasive, whether the patient is having muscle invasive, and whether the patient is having low-grade tumor or whether the patient is having high-grade tumor. So, according to this classification, we further treat the patient. In some cases, like if the patient is having non-muscle invasive bladder carcinoma or low-grade tumor, a practice is followed which is called instillation of BCG. We instill a BCG into the patient bladder every weekly for 6 weeks, which is induction schedule. Then after maintenance schedule, we induce a immunoresponse in the bladder to kill the micrometastatic, to kill the microcells in the bladder. This also treat the bladder carcinoma, and we keep the patient on the regular follow. If the patient is having muscle invasive bladder carcinoma, we give the option of the patient to radical cystectomy. It is one of a kind of a surgery in which the whole of the bladder is removed along with the lymph nodes which is affected with the carcinoma bladder, and along that we make a new pathway. Because the bladder is removed, we cannot store the urine in that bladder because that part has been removed. So we make a there are two options available then. Either we make another opening in the abdomen from where the urine will pass continuously, and we put a bag there, which is called as ileostomy, ileal conduit. And the another thing, we make a neobladder. We make a new bladder through our intestine, through our ileum, through our sigmoid. We make a new bladder in which we join the ureter so that the urine can collect in that and the patient can pass via its normal route. There is no need for opening in the abdomen through which urine pass continuously. So in some patients, radical cystectomy is done. As I said, if radical cystectomy is done, it is the best thing if it can be done because it can remove all the part of the tumor. Then there are other options available, like in this also we can give radiotherapy to reduce the size of the tumor, but it is not very effective proven. Then if the patient is having recurrence after surgery, like patient is having again development of cancer nodules, we do a regular follow-up. If again patient develop tumor, then we go for a immunotherapy, like various immunotherapies are available, which can be given with the consultation of a medical oncologist. And but the main part in bladder carcinoma management is its follow-up. Patient have to be regularly followed. Once the patient lost to follow, that means the patient cannot be recovered properly. He has to come regularly to the doctor so that he can be followed till 5 years, till 10 years, so that the chances of recurrence can be terminated. Yes, ma'am.
Right, Dr. Ajay. So, follow-up is an important part of urinary bladder.
Follow-up is an important part of every type of carcinoma, but in bladder carcinoma, it is the
becomes
very
all the more
important part.
imperative. Right. Coming to testicular malignancies, how are they? What are the typical signs and symptoms if somebody is having that problem, and how is it diagnosed?
Ma'am, testicular malignancies are, if we count regarding the epidemiology, it is around 5% of all urological tumors. It is not as much common as prostate or bladder carcinoma, but patient present with the hard palpable mass in the testis, which is rapidly growing, and sometimes hematoma is present. Patient will have decreased weight loss, decreased weight, decreased appetite. These all symptoms cumulative can point out towards the diagnosis of testicular malignancies. Similarly, in diagnosis, first we take history regarding the swelling of the patient. Then we clinically examine the patient, whether the mass is hard or soft, whether it is mobile or fixed, all that characteristics. Then we do a ultrasound. In ultrasound, we get to know regarding the heterogeneity of the mass, regarding the characteristic of the mass. Then we diagnose as testicular malignancies. In testicular malignancies, there is a peculiar thing. We do serum tumor markers, which is very, very important in testicular malignancies per se. However, tumor markers are also available in bladder carcinoma and prostate carcinoma. But they don't aid in the diagnosis of that cancer. But in testicular malignancies, tumor markers help in the diagnosis of tumor. There are basically three: beta HCG, alpha fetoprotein, and LDH. We do these three tumor markers, we do clinical examination, and we do radiological investigations. All these combined will diagnose towards the testicular malignancies. So this way we can diagnose a testicular malignancy. Now,
What about the treatment journey when we talk
ma'am, the first and foremost treatment is removal of the cancerous tissue. So in testicular malignancies also, we remove the testis, which is we called as high inguinal orchidectomy. We do not simply do orchidectomy by scrotum. We do a high inguinal. We put an incision in the inguinal area and remove the testis from there. Before doing that, we also do a CT scan of the abdomen, because the testicular malignancy frequently invades our lymph nodes in the abdomen, which is called retroperitoneal lymph nodes. In that kind of lymph nodes, if the patient is having that kind of situation that their lymph nodes are involved, then we also had to do a RPLND, which is called retroperitoneal lymph node dissection, which is a big surgery. We have to remove all the involved lymph nodes, and a difficult surgery also, but have to be done to remove the metastasis to that tumor. So in testicular malignancies, prognosis is also not very good, because if the lymph nodes are involved, all the lymph nodes, affected lymph nodes cannot be removed. And after RPLND and after testicular removal, we have to give chemotherapy to the patient. And some patients do very well, but this is the treatment part which we do with testicular tumors.
Right. Coming to penile malignancies, what are the symptoms? How would you describe the whole, diagnosis process? How is it diagnosed? What is, please enlighten.
Ma'am, penile cancer is not very common cancer. And especially nowadays, it is also becoming less common due to increased awareness, increased doctor availability, and increased facilities available, so that the patient can go and check to the doctor in the initial part of their disease. Mostly it is present as any lesion in the penis part, any ulcer in the penis part, any growth in the penile part. Sometimes patient is having warts in the penile part. These all are the most common presentations which the patient present to the doctor. First, if the patient present with such symptoms, we first examine and evaluate the patient. If there is growth in the penile part, we take a wedge biopsy. We take some part of that part and send it for biopsy. If it comes out to be malignant, then, as already said, in every malignancies, the mainstay of the treatment is removal of the cancerous part. In this malignancy also, we remove that part. If the now the it depends on the invasiveness of the tumor, and also the size of the tumor which is involved in penile part. Like if the glance of the tip of the penis is involved, we do a partial penectomy. We just remove that tumor, send it for biopsy. If the margins are negative, it's done. Then if the whole of the penile part is involved, we do a total penectomy. In that total penectomy, we remove whole of the penis and make a new opening for urination, so that the patient can urinate. Similarly, like testicular tumor, the prognosis of penile tumor is also very poor, because in penile tumor, our lymph nodes, inguinal lymph nodes, are very commonly involved. If the patient is having involved lymph nodes, very large tumor, then prognosis is very bad. Even after doing lymphadenectomy, removal of that involved lymph nodes, patient usually do not survive beyond 2 to 3 years. So in such cases, the mainstay of treatment is penectomy, lymph node resection, and chemotherapy. So this is the mainstay broad treatment for the penile cancer.
Cancers, right? Talking about prevention of malignancies, you think when we talk about I want you to cover two aspects: risk factors, when we talk about what are the common risk factors, and how can we, because the whole health discourse is moving towards the preventive approach. So when we talk about malignancies, does prevention work there? What is the status? Please enlighten us.
Ma'am, regarding the risk factors, all the malignancies having common risk factor, which is smoking, tobacco chewing, exposure to any carcinogenic material. Like in bladder carcinoma, most patients smoke. We found most patients having history of smoking, or the females having history of hookah smoking, or making rotis in chula like they did in previous times. So most patients having that history. Also, occupational exposure, like the people working in the dye industry, they are exposed to various chemicals. They are also more prone to having carcinoma. These are the risk factors. If we talk about specific malignancy, like in testicular tumor, if the patient is having cryptorchidism, which is absence of the testis since birth, sometimes patient came into our ward with single testis, and one testis is in the abdomen or in the inguinal area, which is called cryptorchidism. Such factor is predisposing factor for malignancy. Like penile cancer per se, phimosis, that means inability to retraction of prepuce is the common risk factor. So in Muslim populations, the chances of penile cancer is negligible because they are circumcised since birth. So every malignancy has its peculiar risk factors, but the most common risk factor is smoking, alcohol consumption, and occupational exposure to carcinogens, and familial. Like in prostate cancer, hereditary prostate cancer is common. Bladder cancer can also be hereditary. So these all cumulative causes malignancies, but we cannot point out a single one factor that which can be avoided and we can say that you are safe from malignancy. So every malignancy has its own risk factors, but the most common are smoking, tobacco chewing, alcohol, and occupational exposure.
So that was indeed a very insightful discussion, Dr. Ajay. Any other point that you feel is important?
Yes, ma'am. I just want to say that for the prevention of malignancies, there is no any medications which can prevent malignancy. Many patients came to us and say, sir, kindly give us some medication so that we can be prevented from malignancies. There is no medication available, ma'am. And how can we prevent? We can change our lifestyle. We can change our dietary habits, like inclusion of more antioxidants in the form of green vegetables, in the form of antioxidants, in the form of flavonoids, in the form of soy proteins, and avoidance of smoking, alcohol. We can just do our dietary changes. We can just avoid our bad habits, or we can just do a healthy lifestyle, which we can adopt. Just these things we can done to prevent us from these things. Otherwise, there is no medication or no other method available which we can prevent ourselves from that malignancies.
Thank you, Dr. Ajay. That indeed was a very insightful discussion, and I'm sure our audience today will take away a lot of relevant information as far as malignancies in urology are concerned. Thanks for being a part of this discussion.
Thank you, ma'am. My pleasure, ma'am. Thank you. Thank you.
And for our viewers, thank you for watching us. And for more updated information on health and well-being, please keep on following our social media pages. Thank you.